If you look at my patient population, they're mostly alcoholics who smoke a lot. And so in the United States, we're very health conscious nowadays, or at least we try to be. So less and less people are getting head and neck cancer because of the lack of smoking and drinking. Now, globally is not the case. There are some countries where, for example, India, where they chew something called betel nut, and this is a very carcinogenic type thing, and they get a very large rate of oral cavity cancer. So globally, it's much more common. And even if you look at the death rates, also globally much worse than the United States. Now, what is head and neck cancer? When I tell people, they ask me what I do for a living. And I tell people I'm a head and neck cancer surgeon, and they're always never sure what I do. Like, what does that mean? Are you a brain surgeon? Are you? So I say, well, I do, cancer of the tongue, for example. And usually their statement is, you can get cancer of the tongue? That's what they say. But the bottom line is head and neck cancer basically involves the mucosal lining from the lips down to the esophagus. So if you look at all the pink lining in your mouth, which is a large amount of it, that's what head and neck cancer is, of that area. And it's pretty diverse. If you look at the different, let's call them nooks and crannies in your mouth, there are a lot of different areas. For example, you can think of the back of the nose, which we call the nasopharynx, is different than the oral cavity, which would be the tongue, the floor of mouth, and the teeth, which is different than the back of the tongue and the tonsils, which is different than the voice box, which is called the larynx, and the hypopharynx, which is the bottom of the throat. So each of these areas are actually different in my mind, and some of them require different treatments. Some of them have different prognoses. So even though I'm a head and neck cancer oncologist, the bottom line is that each one of these different areas is actually different, and you have to kind of know the differences between them. If you look at the histology, in other words, what types of cancers that people in the head and neck get, most of it is what's called squamous cell carcinoma. If you look at this purple pie chart, about 95% of the cancers are squamous cell carcinoma. There are other cancers that I deal with in the head and neck. Minor salivary glands, you have little spit glands in your mouth that you can get cancer of. You can get melanoma, you can get lymphoma, you can get sarcoma, but by and far, the most common cancer that I deal with is squamous cell carcinoma, which is cancer of the squamous cells of the mouth, which are basically that pink lining that I was talking about before. So, people like to think sometimes that just one day you get cancer and it just kind of shows up, spontaneously. But in the oral cavity, and I think in many other cancers as well, there's a progression to cancer. And so there are precancerous lesions, and I think you need to know what these precancerous lesions look like so you can identify them either in your own mouth or the mouth of your family members, so you can then prompt that to be evaluated by a doctor. So there's something called leukoplakia, and that sounds like a really fancy long word, but basically it means white plaque in Greek. A white plaque is a pre-malignant lesion found in the oral cavity. Now these leukoplakias, which is basically a clinical diagnosis, in other words, white plaque in the mouth, is basically can turn into oral cavity cancer or head and neck cancer in about somewhere between, if you look at the studies, about 0 to 20% of the cases. And that can occur over a relatively short period of time of a year, but it can almost take 30 years for the leukoplakia to turn into cancer. And what does it look like? If you look, I don't know if you can see these very well. This is someone's mouth. This is not a Fanconi anemia patient, just a regular patient. And you can see here are his teeth, and you can see there's a white kind of thickened area of mucosa, which is what we call leukoplakia. Here, this is a relatively small area, kind of on the buccal or the inside of the cheek, but it can be a pretty large area, and some patients almost have their entire mouth filled with this precancerous leukoplakia. And here's a tongue. I don't know if you can see that, but you can see this irregular thickened area, which is this precancerous thing in the mouth. There's also something called erythroplakia, erythro being red, plakia meaning plaque. So this is a red plaque. Again, this is a precancerous lesion. It has a far much greater probability of turning into cancer than leukoplakia. So if you have a choice between whether you want leukoplakia or erythroplakia, erythroplakia is a much more serious situation. Most of these lesions have a kind of a flat, kind of plaque-like velvety appearance, and they're usually red, and they can be speckled with white. there's something called speckled erythroplakia, which means there's leukoplakia intermixed with erythroplakia, so it's like red and white. And these are more dangerous in terms of the rate of cancer development, or cancer in these lesions is higher, almost 50 to 90%. So usually in my practice, when I see an area of erythroplakia, that 100% gets a biopsy, and 100% a lot of times needs to be removed. Here's an example. Here's the same buccal area, that inside of the cheek with a red kind of plaque region. Here's a tongue with it's hard to see, but this kind of has a raised red plaque. So as I was telling you, cancer doesn't usually develop from just nothing to cancer. There's a progression, as I was telling you. And this is what's called oral dysplasia. So what happens is that the cells in your mouth or in your throat will start off as atypical. They start to turn, they're gaining mutations which change them, and then they collect mutations along the way that continues to change them, and then eventually into cancer. So oral dysplasia is definitely a precancerous lesion. It has an increased likelihood of progressing to squamous cell carcinoma. And these are basically slides. This is what the pathologists look at. And you can see this is what normal lining of your mouth looks like under a microscope. But as you go up towards severe dysplasia and then carcinoma in situ, you can see that the cells look abnormal. And this is how it progresses from relatively normal to cancer. And this is just kind of an example of that. You can see on the top here, this is a benign area. Here's some dysplasia. Here's some carcinoma in situ. Carcinoma in situ means that it's just the lining. The cancer hasn't invaded into the deeper structures. And then carcinoma, and then increasing in size. So one thing you'll notice that within the mouth, a lot of times you'll have areas of dysplasia, and then next to or within it, you'll actually have cancer developing within it. And this is, you can see the progression as time goes on with these lesions. And if you look here, this is a little bit complicated for this group, but the bottom line is mutations are happening at every step along the way that's causing it to go from a normal cell to a cancer cell. I don't know if everyone understands that, but basically you can collect different types of changes in the cell structure that allows it to go into cancer. So squamous cell carcinoma, how do we recognize it? What does it look like? This is very important because you really want to, if there's a lesion in the mouth, is it something that's just an ulcer, like a canker sore, or is it something more serious? Squamous cell carcinoma usually has irregular borders. In other words, it's not just if you ever look at it, you've all had canker sores, that little white thing that hurts in your mouth. If you ever see them up close, they look like almost like someone took a little white punch out of your tongue. It has a very nice little clean edge. It's usually pretty painful, and then it goes away after a couple weeks or a week or so. Cancer does not do this. Cancer usually has irregular areas. It looks lumpy. It usually has raised margins, so there's a difference between the regular normal mucosa and the tumor. It can be exophytic, which means that it can be it looks like a blob sticking off your tongue. It can be infiltrative, which means that it's growing into the tongue. In other words, it's like almost you can't see it, but it's firm. And then it can be verrucoid, which verrucoid means wart-like. It looks like a large, irregular wart in the mouth. And it can mimic lesions. I've had situations where it looks like a relatively benign thing, and I take a biopsy and it's cancer. Most of the time, though, it has very characteristic look to it. So let's take a look at some pictures. And again, this is a little bit of the scary part that I've been talking about. But here, if you see here in the very back of the tongue, I don't know if you can see it, there's a small little cancer. You can see it's kind of irregular. It does not look like a canker sore. It's more thickened, it's firm, and it's painful. Here's a much bigger one. You see how it looks kind of ugly. It has an ulcer to it. It's kind of raised off the mucosa. So if you look at it, this is normal mucosa here, and this is the cancer in the back of the tongue. Here's a very classic example of a cancer on the lateral part of the tongue, and I'll just describe some of the things to look for. If you look here, this is normal lining of your tongue. But you see how there's almost like a raised border around the lesion, and you see how it's irregular. It's not like a round thing. It's kind of like shaped like almost like a heart, I guess you would say. And you can see here, it's kind of lumpy and irregular inside the middle. This is that irregular mucosa that I'm talking about. This is a classic example of a squamous cell cancer of the oral tongue. Here's an up close of that. And you can see how it's kind of, again, a little bit irregular, kind of lumpy and white, and it's thickened. And usually it's painful or it feels harder than a normal lining of the mouth. Now, head and neck, I just showed you kind of the oral cavity cancers, but these are different types of tumors. Here's a tumor along the gum line. I don't know if you can see it. Here, this is normal gums, and this guy needs dental work, but bottom line is, here is an irregular lesion along the gums. This is called alveolar ridge carcinoma. This is your voice box. It's not really a great picture, but you can see that it's swollen, and there's a cancer along the vocal cord on that right side. And here is a cancer of what's called the epiglottis, which is basically part of your larynx. Here's another example. You can see that they sometimes can be very large and ugly. Here's a small cancer along the alveolar ridge. Here's a cancer that has taken over almost the entire floor of the mouth. So I hope you get an idea what they kind of look like. So what are the predisposing factors to head and neck cancer? As I told you before, head and neck cancer most commonly in the general population is related to smoking and drinking. As I said, about 85% of my patients are very large smokers and drinkers. And it's very hard to treat them because a lot of times they continue to smoke and drink, which is not so good for them. I was talking about betel nut. That's again another, and chew, like smokeless tobacco, chew. This is also a risk. A lot of people do it again in foreign countries. Viruses, which we will talk about. Human papillomavirus has been now implicated in tonsil cancer and oropharyngeal cancer in the general population. Epstein-Barr virus, which we also call EBV, is associated with something called nasopharynx cancer, which is cancer in the back of your nose. This topic, this HPV virus topic, is a very hot topic in the head and neck world. I go to meetings almost a couple times a year, and I would say about half the talks in these meetings are about human papillomavirus. So I'll talk a little bit about it. There's a big controversy about Fanconi anemia and HPV, and I'll mention that in a little bit. And of course, there are some genetic predisposing syndromes or diseases that have an increased rate of head and neck cancer. There's something called Lee-Fraumeni syndrome, which is a mutation in the P53 gene that you're born with. P16, which is related to HPV, you can have a mutation of that gene, which again increases your rate of head and neck cancer, and of course, Fanconi anemia. So one thing I want to talk about is smoking and drinking, because I know for a fact, because I see a group of patients with Fanconi's anemia who I've treated with head and neck cancer. Some of them do smoke and drink. So smoking and drinking is a big problem in the head and neck cancer world. If you look at this, more than 2 drinks a day, you can see that the rate of head and neck cancer increases. If you combine that with smoking more than 1 pack a day, you can see that the rate is very high, which is this particular, more than 1 pack a day, more than 2 drinks a day, very high rate of head and neck cancer. And it's all linear. In other words, you can see that it goes up the more you drink, the more you smoke. So what are the prognostic factors? Prognostic factors are what things matter when I consider staging and treatment and how patients are going to do. The site of where the cancer is. Remember I was telling you before that each site is almost different. So depending on whether it's a lip cancer versus a throat cancer, there is different prognostic situations with that. The size, we also call that the T stage or tumor stage. The size of the tumor, obviously the bigger the tumor is, the worse the prognosis. The location, tumors that are more anterior in your mouth usually have a better prognosis than tumors that are further back in your throat. Cervical node status. What that means is that metastases to lymph nodes. Head and neck cancer frequently likes to spread to lymph nodes in the neck. It's probably the most important factor that I have to think about when I'm trying to decide how to treat patients and their prognosis. I would say that is the most important. If you look at the prognosis, if you have positive lymph nodes at presentation, in other words, you have lymph node metastases in head and neck cancer, the prognosis goes down by 50%. Okay? And then, of course, there are other things, the grade, the depth of invasion, and host tumor factors, which are important for prognosis. If you look at the location and survival, I was telling you that the further forward it is, the better the prognosis. And so you can see here, this is the 5-year survival in head and neck cancer. Lip cancer has almost a 95% 5-year survival. And as you go further back in the throat, which is the hypopharynx, and the pharynx, which is like the back of the throat, the rates are pretty poor. You can see here for hypopharynx cancer, which is cancer of the entrance to the esophagus, the 5-year survival is somewhere around 20%, which obviously is a very poor prognosis. We talked about stage. We use something called a TNM stage. T stands for tumor size, N stands for lymph nodes in the neck, and M stands for distant metastases. So basically, this is how we stage the tumors. So depending on those three things, we stage the tumors into stage 1, stage 2, stage 3, and stage 4. At presentation, this is for the general population, most of the tumors we see are stage 1 and stage 2. Stage 3 and stage 4 are a little bit less. But if you look at the survival, and this is 5-year survivals, you can see that it goes down as you go from stage 1 to stage 4. How do we treat head and neck cancer? Head and neck cancer is treated with a combination of different types of modalities. Surgery being probably the most common, but we also sometimes don't do surgery for certain types of tumors, and we do radiation plus or minus chemotherapy. Sometimes for very advanced cancers, we do surgery plus radiation plus chemotherapy. So we do all three. There's also, and that's what I said here as combined modality treatment. So in people who have very large tumors with cervical metastases or neck metastases, most of them will be treated with surgery plus radiation plus or minus chemotherapy. Now, one of the things, if you take a poll of my hospital and say who deals with most of the other departments in my hospital, they would probably come up with me as one of the main people. I know everyone in the hospital. And the reason why I know everyone in the hospital is because when you're a head and neck surgeon like myself, it is a team approach. I can't do treating head and neck cancer patients by myself. The reason why you can't is because you need all these other people, all these other experts involved in the patient's care. You need a radiation oncologist, you need a medical oncologist, you need an endocrinologist, a nuclear medicine person. A lot of times you need plastic and reconstruction. You need dental and prosthetics, psychiatry, nutrition, nursing, all this stuff, pathology. And I think if you look at a lot of the community hospitals, a lot of them don't do head and neck cancer work. And the reason why that is because you need all this expertise to really give you the best chance for the patient to do well. Because it's not just me. In other words, I could do surgery and the surgery goes beautifully, but if they don't have a good speech pathologist or a swallow therapist, the quality of life for that patient could suffer. So I need the whole team on board. And that's probably why I know more people in the hospital than anybody else. One of the things I want to talk about is that even though you can treat these patients successfully, and I have treated many patients successfully, you always have to worry about the tumor coming back. And I think that's obviously with all cancers. Most of the cancers in head and neck, usually if you look at this, and I'm going to look at the red line here, most of the local recurrences, in other words, a tumor coming back, is usually occurring within the first 2 years. If you can I usually tell patients, and I see these patients for the rest of their life. I usually say that, it's their 2-year anniversary with me. In other words, I treated them and it's 2 years now. I say, listen, the chance that you're going to have a local recurrence, goes down significantly if it gets past 2 years. You can see that at past 3 years, it's almost, the chance of recurrence is very low. And it's the same thing for both distant metastases and lymph node metastases. But however, one thing that I do want to point out is this light blue line. I don't know if you see it. Most of the green line, the red line, and the yellow line all after about 2 or 3 years kind of go down. But this light blue line continues straight across. And what that is that's the second primary cancers. In other words, I could treat successfully the primary cancer that I treated, but a lot of these patients in the general population, and we'll talk about Fanconi anemia patients, the risk of another cancer developing either in the head and neck or another smoking-related cancer continues 7% per year. So I've been in practice 15 years now, and there are patients that I've seen for 15 years. In other words, I continue to see them for the rest of their life. So I want to present a case, and this is where I'm going to now. So everything that I've spoken to you before is basically general information about head and neck cancer. So now I want to switch gears a little bit and talk a little bit about Fanconi's anemia and its relationship to head and neck cancer. So this is a patient, a 33-year-old FA male. He has a history of a bone marrow transplant as a child, who has a long history of oral leukoplakia, erythroplakia, and oral dysplasia, which is basically covering most of his tongue, throat, and mouth. So if you look at inside his mouth, he has irregular kind of white patches, red patches, basically coating most of his tongue. Nothing specific cancer-wise, but that's what he had. So I saw him. He was diagnosed, came to see me with a cancer in the back part of his cheek, inside. I looked at it and I did a biopsy and it was cancer. So we basically took him for surgery. We removed the inside lining of his cheek and did a neck dissection to remove the lymph nodes in the neck. All the margins were negative. In other words, the entire cancer was removed, and he had no positive, even though I took the lymph nodes out, he had no positive lymph nodes in the neck. So I did not treat him with any additional therapy. He got no radiation, no chemo. Now, as I told you, I follow patients for the rest of their life. So I followed him pretty much every 3 months for 7 years, okay? But he continued to have these areas of leukoplakia and dysplasia. In other words, he had these precancerous lesions, but I can't remove all the lining of his mouth. So I just was watching him very, very closely. So then he developed a second cancer further back along the cheek 7 years later. But because I was following him so closely, I caught it relatively early, and we were able to resect it, and then he's been fine. Now it's another 3 years, so he's 10 years out from his first cancer, 3 years out from his other cancer. Now I still follow him. I saw him relatively recently. I did another biopsy of an area that I was concerned about. It came back negative, but the bottom line is that this kind of patient, and you see the reasons why, has to be followed very closely. And if I can catch the early tumor, as I told you, the chance that I can cure him or cure that specific cancer is very high. So let's talk a little bit about head and neck cancer and Fanconi. The reason why we're concerned and the reason why I'm here today is that Fanconi anemia patients have a very high rate of head and neck cancer compared to the general population. Remember, I was telling you in the very beginning, head and neck cancer in the general population is very rare. If you look at SEER data, which is basically population data that the NIH collects, it's about an expected incidence yearly of 0.0338%. Okay, so pretty low. But if you look at the Fanconi anemia population, the incidence over time is about 20%. So you can see it's about a 500 to 700-fold increase in the rate of head and neck cancer for Fanconi anemia patients. And this is why I'm here talking to you today. If you look at the incidence by age, you can see most of the cancers really start to occur when the FA patients are 20 years old. But you can see by the age of 40, there's a 21% chance or incidence that that 40-year-old will get cancer, which is of the head and neck, which is an exceedingly high rate of head and neck cancer for this kind of population. Most of them develop head and neck cancer at a young age. Most of my patients who are the smoker drinkers that I was talking about before are in their 50s, 60s, and 70s. Most of the patients in the Fanconi anemia population are somewhere between 15 to 49, at least in this study. I've heard of earlier people and older people. This is just one study. If you look at the median age, it's about 30 years of age that they get the head and neck cancer. The female ratio is a little bit more. I'm not sure exactly why that is. But you can see there's still some percentage of the Fanconi anemia patients who do smoke and drink, but it's much less than the general population. If you look at where most of the cancers occurred in the head and neck region, for whatever reason, and no one really is quite sure, most of the head and neck cancer in the FA group was in the oral cavity. And when I say oral cavity, that's the lips, the gums, the floor of mouth, and the tongue. Okay, that's where most of them get their cancer for whatever reason, and much less likely in the throat and in the voice box. If you look at the general population, it's different. Oral cavity is still pretty significant, but probably voice box cancer is much higher, and that's probably related to smoking, as I was telling about before. If you look at the staging, comparing Fanconi anemia patients to regular general population patients, you can see that a lot of the patients, at least in this particular study of like 21 Fanconi anemia patients, most of them were either stage 1 or stage 4. And most of the stage 4 was because they had positive lymph nodes in the neck. Okay? If you look at the general population, it's a little bit, for whatever reason, more diffuse through the stages. Prevention, obviously, tobacco and alcohol. I do see patients that, Fanconi anemia patients that smoke and drink, and I tell them very carefully and very specifically that they should stop that. Obviously, you can't change habits. You can't change people. Sometimes I wish I can go home with people and say, stop smoking, every day. But you can't, and they still continue to smoke. Secondhand smoke is also important. You should probably avoid that as well. So if you smoke and you have a patient who already is at high risk for head and neck cancer, you're obviously putting your loved one at risk equally. So that's something to be concerned about. And then obviously we have to talk about the role of HPV and other viruses and vaccination. And that's what we'll talk about now. Now, this is another disclaimer that I have. Now, there was a lot of discussion probably a bunch of years ago about HPV and Fanconi anemia. Then there were other studies that came out which said that it really wasn't involved, and then back and forth it kind of went. But I think the reason why I'm presenting HPV to you is because HPV, I know for a fact, and this is data that's not just from mine, but from across the head and neck world, that HPV does cause head and neck cancer in the general population. So I think if you have to understand head and neck cancer, you have to understand HPV. Okay? And that's why I'm presenting it. Whether it causes HPV cancer in Fanconi anemia is up for debate, and probably not, but the bottom line is you should understand HPV because it is a very important role in head and neck cancer in the general population. So if you looked at some of the data, and again, initially the data was thought that there was a higher rate of HPV compared to the general population in Fanconi anemia patients. Most of them were HPV type 6T. Now the bottom line is, when you have in the general population HPV positive tumors, and this is a very important thing that I'll say today, HPV positive tumors in the general population have a better prognosis than the smoker-drinker patients that I talked about before. So if you are HPV positive, the prognosis is better. So most people that I diagnose with HPV positive head and neck cancer are happy that I'm telling them there's HPV in there because the prognosis is better. They do better across the board. And that's been proved by many, many studies at this point. But many people think that it's a distinct disease compared to the general population who smoke and drink. So now they're dividing head and neck cancer into HPV positive tumors, which are better, and head and neck and smoking, drinking related tumors, which are worse. Okay? So they think it's a completely distinct situation. So even though it's important in the general population, the question whether is it important in the FA. So let's talk a little bit about HPV. HPV is a small DNA virus. It was first identified in 1949. There are actually many types of HPV. I think some people group HPV, they think it's just one virus, but there's actually 120 different types of HPV. It infects the bottom layer of the mucosa that I was talking about, that pink lining. There's a basal layer, and that's where it infects and gets into the cells of the lining. It likes to replicate. In other words, any virus needs you as the host, the human, to replicate within the cells. So it can't replicate on its own. Okay? It has to have a host, which is the human. And it basically requires our own DNA to replicate within the human. There are many different subtypes, as I was telling you about. There are benign subtypes, and then there are high-risk subtypes. Low risk would be HPV 6 and HPV 11, and then there's, of course, the oncogenic types, or the cancer-causing types, which I listed here, 16 through 35. There's different types cause different types of cancer in the high-risk group. We've all had warts on our fingers. There's a type of HPV that causes warts in our fingers. There's a type that causes skin cancer, which I think the next speaker may talk about. HPV 6 and 11 causes benign lesions like anal warts and oral warts that we sometimes see in the mouth. And then there are these high risks that cause cancer, mostly in the tonsil and the back of the tongue region. HPV 16 is the most common type. That's what most people are talking about. About 90 to 95% of the HPV positive tumors are from this HPV type 16. It's relatively small, and it has different proteins that it makes in order to basically replicate and do its function in the body. This is a scanning electron microscope, what it looks like under the microscope. These are the different proteins that it makes. This is a little bit scientific, I apologize. But how does it work? And this is very basic. It actually is pretty complicated. But what it does is HPV makes these two proteins, which are called E6 and E7. These are early protein 6 and early protein 7. And what it does is it turns off tumor suppressor genes in the cell, and then this basically allows the tumor to progress. It disrupts the p53 pathway as well as the retinoblastoma pathway, and it does a lot of different things, which I'm not going to go into. This is the complex system that it does. But the bottom line is what it does is from a normal infection, it gets into the lining of the mouth or the throat, or it could also be the vagina or the cervix. And what it does, it enters, it goes to this basal layer, and for whatever reason, it starts infecting this basal layer, and it starts making more protein, and that allows it to replicate within this layer. And somehow, and no one really knows why, some people clear the infection and get rid of it, while others, the DNA of the HPV incorporates into our DNA and then changes the cells. And this is what happens in some patients, where it allows the cells to proliferate, and eventually it turns into cancer. Now, why some people clear the disease and why some people it goes into cancer, no one at this point knows, and no one can tell you that information right now. There are vaccines that we've been talking about, and this is probably one of the most successful vaccine programs that's known. There's been mostly done in cervix cancer in women, and by getting the vaccine, the rate of cervix cancer has decreased already, and this vaccine's only been a bunch of years old at this point. So we've really done some very good things by giving the vaccine. And the question is, should we start? Right now, most young women before the sexual age are getting the vaccine. I know my kids got it. I have 2 girls myself. And the question really becomes, should we start giving it to boys as well to prevent head and neck cancer? And I think the answer is an astounding yes. I think most people believe that, and there are boys now who are getting the vaccine to prevent tonsil and oropharyngeal cancer. The question is, should Fanconi anemia patients get it? And I think yes. Even though there's a lot of controversy whether HPV is important for Fanconi, I don't see any downside of giving the HPV vaccine for patients, especially when we know it's a known risk factor in Fanconi in the general population. It's based on 2 companies make it at this point. There's a Merck called Gardasil, which is probably the most common, and then there's another vaccine called Cervarix. They do different types, but the main type, which is type 16, is covered in both of them. It definitely decreases the incidence of these HPV infections, especially in cervical dysplasia, and the question is, it probably does the same thing in oral dysplasia as well. It's designed to initiate protective immunity. In other words, if you already have the virus, it doesn't really do anything. What it's supposed to do is it's supposed to prevent you from getting the virus into your cells. In other words, getting the infection with the virus. So it's a humoral response. It prevents an HPV infection in unexposed patients. So if you think about it, how do we get exposed to HPV? It's through sexual contact, passing from one person to another through sexual contact, either deep kissing versus sexual contact, in other words, intercourse. And the bottom line is you have to give the vaccine before that happens. Because once you get the HPV, it doesn't really do too much. There's many animal models looking at potentially using it as therapeutic use, but really that's nowhere at this point not common. So how do we treat squamous cell carcinoma in FA patients? I think by and large, most people with Fanconi anemia and head and neck cancer will be treated with surgery. And you can imagine, all of you know that Fanconi anemia is a DNA chromosome instability issue. So radiation and chemotherapy don't go well all the time with Fanconi anemia patients. Surgery can be done successfully, and I've done probably about 12 cases of Fanconi anemia patients, 12 patients, and successfully treated with surgery. The problem with head and neck cancer, as you can imagine, is your head and neck is kind of important. You breathe through it, you eat through it, you talk through it. So when you do surgery in the head and neck region, it can decrease your quality of life to a certain extent. because you're removing things that are important for all three of those important functions. So a lot of times, especially for large surgeries, for large tumors, we do large surgeries. There's a large amount of tissue dissection, there's surgical complications, there's morbidity related to the surgery itself. But most of the surgeries, to be frank with you, are successful and can be done relatively straightforward. There are new items that are coming, or new procedures that are done. One of the things that very strongly being promoted at this point is robotic surgery, okay? To basically remove tumors from the oral cavity and oral pharynx without making big incisions in the mouth and throat. So what we've been using is a robot, and I do this surgery probably about twice a month now. I'll have a patient who undergoes robotic surgery. And what it is that as time has gone on, we realize that we can use these techniques to do what we call minimally invasive surgery. In other words, we try to reduce the morbidity of the surgery by doing less surgery to get the tumor out. The bottom line is we still need to remove the entire tumor, but we can do it in a less morbid way or less problematic way. So we've been using this machine called the Vinci robot. This is the main one that's been commonly in hospitals. It's basically, if you look at it, this is the robot here with the arms that come out of it. You basically seat the robot at the head of the bed, and you put these arms in the patient's mouth. These little arms are 5 millimeters. So if you look at my hand, I don't know how big it is, but it's pretty big. These little arms are about this big, 5 millimeters, and I can stick these little arms in there and actually use the robot to control and cut out the tumor without getting my hands in there. The way it works is that you can sit at this console and you control the robot with these controls which are sitting below the console. So if you think about it, I'm across the room controlling the robot with the patient over here. It was initially invented to basically do it in the Army or when, the front lines where the surgeon can be safe in a hospital somewhere and we can operate at the front lines without having to do it. Obviously that didn't turn out that way, but we can use this robot, and it's been used more and more commonly as people have been getting better at it. This is an example, just to show you, this is the uvula. That's the back of the soft palate. I don't know if you know the anatomy, but you can see here I'm taking out a tonsil. These are the size of these little arms that I use to cut out the tumor in the back of the tonsil. I had a video here. I don't think it's working, so I apologize. So basically you can see that as time has gone on, we're trying to do more and more less morbid procedures, more minimally invasive procedures, but the facts remain that depending on the size of the tumor, we still need to remove the entire tumor. So if it's a large tumor, we still need to remove a large area to remove the entire tumor. So even though we have the minimally invasive techniques, there are sometimes we have to still use the open procedures. So let's talk about radiation. I said to you before that radiation can be difficult in patients with Fanconi's anemia. But I do want to say, even though the data says that that is true, I have successfully treated multiple patients with radiation therapy and got them through it the entire way, okay? And I think for some tumors, for example, high-stage tumors where you need not only surgery, but some additional therapy to make sure the tumor doesn't come back, radiation is our best options at this point. But let's look at some of the data comparing Fanconi anemia and radiation. So this is a study that was published a couple years ago. This is 12 Fanconi anemia patients that were treated with radiation after surgery. The average dose was 5242, about 5,200. Most of the people who get general population who get radiation are about 6,000. So you can see that the Fanconi anemia patients couldn't really tolerate the full dose. They had to have less dose. They had more common toxicities related to the radiation. They had more inflammation and irritation in the mouth compared to the general population. They had more problems swallowing secondary to the radiation. And this is kind of the thing a little bit unique about Fanconi anemia. They had more blood count problems during radiation. Most people in the general population who get radiation, their blood counts are rock solid. They don't change. We don't even draw bloods. However, in Fanconi anemia patients, it's very important. For whatever reason, they'll drop their counts during radiation, and they have to be watched very carefully. So that's something, almost half the patients had pancytopenia related to radiation treatment to the local head and neck region. There were other complications as well, which were more serious. So again, Fanconi anemia patients can be radiated successfully, but they have to be watched much more carefully, and you have to look at the risk-benefit ratio about whether you're going to offer radiation to these patients. The problem is that in about 5 of the 12 patients that we tried to radiate, 5 patients couldn't complete the radiation course completely. They had to stop because of side effects. 8 of the 12 patients died, whether it was related to the radiation or not, and 4 during the course of the radiation. So 4 of those patients who had 4 of the 5 patients with pancytopenia during the radiation unfortunately died during the radiation course. So that obviously is not a good situation. So I think the bottom line is, and I think this is what I want to leave you about radiation, I think radiation should be used for high-stage tumors. In other words, tumors where the chance that the tumor is going to come back and cause the patient problem, radiation should definitely be an option, okay? However, it should be administered by people who understand the complicating factors related to Fanconi anemia radiation, okay? In other words, you may need to give a smaller dose. You have to watch the blood counts very carefully during the radiation course, and you have to be very on top of the patient getting the radiation, okay? There were patients who received chemotherapy. They did not tolerate the chemotherapy well. This is basically, and the chemotherapy that was used, goes back a while, was cisplatin, which is basically a very difficult chemotherapy to take when you're a patient in the general population. Fanconi anemia patients did not do well with cisplatin. Now, I do have to say, and I'm not going to talk about this, there are other chemotherapies in the pipeline and then currently being used that are more targeted therapies. One of them is called Erbitux, which is a EGFR inhibitor, which is less toxic in the general population and probably is less toxic in the Fanconi anemia patient. I have only seen 1 or 2 patients where Erbitux was used. One of the big problems that I talked about before are second primaries, okay? So even though I could successfully treat patients with Fanconi's anemia, with head and neck cancer, 63% of them developed other malignancies during their lifetime, and 5 of the patients that was studied in this study had 2 or more malignancies during their lifetime. So constant surveillance of these patients is important, not only for head and neck cancer, but other cancers as well. Most of the second primaries in the Fanconi group were in the GU or anus and the head and neck. They mostly got, again, the anogenital tract and the head and neck. There were others. In the general population, it's mostly related to smoking. They get lung cancer and esophageal cancer. So you can see there are different things that we have to look for in Fanconi anemia patients. So let's talk about outcomes. And this is, I think, where it gets a little scary for parents. I mean, I have 3 children, and it's definitely, but I have to tell you the facts, and I apologize. The facts are this. Of the 19 patients that was looked at in this particular study, about half had a recurrence of their tumor within 10 months. So in other words, the tumor came back relatively quickly. Most of them were related to either local or regional recurrence. It rarely spread distantly, but that's the same in the general population. So if it's going to recur, it will either recur where the tumor was initially in the mouth or in the throat or in the neck. The problem that we had with some of these patients is even if it was a stage 1 tumor, and we had 7 of those patients, 5 of them had a recurrence locally. Most of the time when you think of stage 1 tumors, the cure rates are higher, but these patients, the tumor can come back. So again, you have to be very vigilant and careful about following these patients. 73% of this population, which is the 19 patients, died from all causes, and about 60% died with cancer. So again, the prognosis, not great. If you look at overall survivals, and this is basically populations, they talk about 2-year overall survival and 5-year overall survival, and you compare the FA group versus the head and neck, the general population group, you can see the 5-year survival was 27%, which means at 5 years, about 27% of the patients were alive without cancer. So what is the treatment approach should we take for Fanconi anemia patients? I think it's important for early detection, and we'll talk about that. I think finding the tumor early is the best way to cure these patients with head and neck cancer. Surgery is definitely the preferred treatment option, and I think surgery can be done successfully. I think these patients can tolerate even big surgeries relatively well. I think radiation can be used, but it's got to be used carefully and in selected patients. So the bottom line is, if the patient has, like the patient that I presented as a case, if your margins are all negative and there's no lymph nodes, maybe not use radiation. Where if the tumor is very large and you have multiple lymph nodes and the chance of recurrence is going to be high, then radiation probably should be at least considered. Chemotherapy should be, in limited circumstances, it's still being studied, and I think as time goes on, I think these targeted therapies are going to be better and better, less toxicity, and probably can be used easier in Fanconi anemia patients. And obviously, there's modifications of treatment. Can we modify the treatment to suit the FA patient? There's no data on this, but there's a lot of discussion to de-intensify treatment in the general population. When I say de-intensify, that means maybe in some patients with good prognoses or who are sensitive to radiation, can we lower the dose of radiation with the same oncologic result? The data's not there yet. And then very close surveillance when they have the tumor. I think we can have a debate about how often these patients should be evaluated. I think routine head and neck screening is important for Fanconi anemia patients, okay? I think a qualified examiner is important. So I think there are many people who evaluate for head and neck cancer. You have dentists, you have oral surgeons, you have head and neck surgeons, you have medical oncologists, you have radiation oncologists. And I think all of those type of physicians can evaluate a patient for head and neck cancer. But obviously, someone who, for example, a local dentist who's never seen a head and neck cancer in his life, maybe is not the best person to do the surveillance. Do you understand what I mean? The age of onset is, again, controversial. Most people believe that the head and neck cancers occur, the youngest one that I've heard about is 12. I think there's been a 9-year-old with head and neck cancer. So obviously, around that time is when we should start screening patients for head and neck cancer. But if you look at the median age, it's about 30 years of age. That's when they really start getting the head and neck cancers that need to be definitely screened. So there are some caveats. I think twice a year would be a reasonable amount of time to evaluate the patient for head and neck cancer, a screening. It takes I would say about 10 minutes for a qualified person to look in the head and neck region and screen the patient. Obviously, you need to increase the frequency if there is some pre-malignant lesion that I was talking about, those leukoplakias, dysplasias, and erythroplakias. I think those need to be followed more frequently because the rate of cancer, that turning into cancer, is much higher compared to a patient who has no lesions in their mouth at all. And then I think if you have had a head and neck cancer, I think it should be at least every 3 months that the patient should be evaluated. Because, again, the 63% chance there may be another cancer that's coming. So I think routine follow-up is mandatory, and what a screening is some controversy. Obviously, a complete examination of the upper aerodigestive tract is important. And that obviously, a chest x-ray, I think, obviously most Fanconi anemia patients have multiple doctors and they're being, screened for other reasons. But I think the upper aerodigestive tract evaluation is important. And obviously a gynecologic exam, which I think you've already heard about, is important as well. So I'll answer any questions. And again, I apologize if I was too blunt or too scary, but I wanted to give you at least the data that I have. And I'll answer any questions that are, that you have.
Have you noticed for the FA patients that have got cancer in their throat, did they have any type of preemptive, was there a correlation as a child of having pain or anything? Because like my daughter gets pain in her throat right. and has trouble swallowing and she feels like it's sometimes just bothering her or it's hot to touch. Right. Did you notice that anything that later that those were the ones that were more likely to develop cancer, or was there any other type of correlation other than seeing the inside of the mouth?
Yeah, what she's asking is, symptoms, does that, I don't think symptoms, everyone has throat pain. If I have throat pain sometimes, difficulty swallowing sometimes, and obviously Fanconi anemia patients probably have more of that on a daily basis, but that there's no correlation between getting cancer later, if that's what you're asking. Obviously, one of the symptoms, and again, you have to kind of take this with a grain of salt. One of the symptoms of throat cancer, okay, would be having difficulty swallowing, pain in the throat, feeling something stuck in the throat, and sometimes they're very vague, the symptoms. I have patients that come to me with very vague symptoms. I look in their throat, there's nothing there. They have reflux, right? But then I have patients that come to me with a lymph node in the neck that I know is cancer, and they say, well, I've had some vague throat pain, and I look down there and there's a cancer, in their, say, tonsil region. The problem with a lot of these cancers in the back of the throat, and I mean this very seriously, is that they don't have a lot of symptoms. They're vague, the symptoms in the throat. So it's hard to answer your question, but I don't think the bottom line is that just because she has throat pain, there's going to be a higher rate that she has throat cancer.
When you're talking about the complications from radiation,
Yes.
did you find that with the pancytopenia there was any correlation to whether they were pre or post-transplant?
Yeah, that's a very good question. I think the patients that, and again, this goes by my own personal experience. There's no data on this. So I've probably radiated about 5 or 6 patients with Fanconi anemia and head and neck cancer. I think the ones who had the transplant for whatever reason did better because they have somewhat normal bone marrow. Where the ones that had more problems had not had the transplant yet, and they have Fanconi anemia bone marrow. And I do think that's true. There's no data to support that, but that's just my sense.
Question, the chest x-ray?
Yeah.
I know in the general population with cancer, that's important because they're high risk of getting pulmonary.
Yeah.
What about FA?
Yeah, I kind of put that up there just because I'm correlating to the general population. But, I don't think there's really, I think Fanconi anemia patients are probably being followed so closely that probably we use it to look for other cancers in the lungs, which are, correlated with the general population. So I would probably just dismiss that on there.
With the XRT, you having to use a lower dose lots of times. Is the tumor more radial sensitive in an FA patient?
Yeah,
or not, or?
It's a really good question. I like to think about this from a scientific standpoint. So if you think Fanconi anemia, the cells are more sensitive to radiation because they have a chromosome instability problem, and you think the chromosomes are going to fall apart more with photons coming at them, just from a purely theoretical standpoint. So you think that the cancer cells would be more sensitive in general, right? But there's no data to really support. I don't have any data, again, to support that. The people who have gotten radiation have gotten lower doses, okay? And the question is whether that lower dose was sufficient enough to prevent the tumor from coming back. At least the ones, again, this is all anecdotal stuff. The ones that I've radiated who did well, they got other tumors other places, but the primary tumor that I radiated, did not come back.
I have 2 questions. Number one, is there any correlation, we talked about obviously FA children, FA adults, correlation with cancer. How about carriers of the FA gene? Are there any correlations with that, a higher incidence of cancer?
The Rockefeller group was trying to do a study of carriers and whether they got a higher rate of cancer. As far as I know, and the study wasn't published, but I know the data, there was no increased risk of head and neck cancer or any cancers in carriers of Fanconi anemia. Now, that's not published. That's just, and it was never published, I assume because it was negative data. But the bottom line is, I don't think there's an increased risk as far as we know with carriers of Fanconi anemia.
My other question is, you're hearing a lot more now about the new types of treatments for different types of cancer.
Yeah.
Especially, it sounds like skin cancer and others. Is that related in this sense too, besides just doing it with chemo and radiation and surgery?
Right. There are a lot of studies looking at head and neck cancer. I ran a trial recently There are other trials all throughout the nation, the country, even internationally. The bottom line is that some of the cancers that you talk about are very simple mutations that we can kind of fix with like gene therapy and various other things, immunotherapy. Head and neck cancer, the reason why it's a little bit harder to do these targeted therapies is it's a very genetically complex cancer. If you look at the different types of mutations and the genetics of it, it's not so straightforward to just use one medication to treat it. But I think as time goes on and we learn more and more about the genetics of head and neck cancer, I think there will be very targeted therapies that would prevent a lot of the toxicity we use from just standard chemo, standard radiation, and standard surgery. Now, whether I'm going to go out of business because we're no longer going to do surgery, probably not, but the bottom line is, I think as in the next decade or so, I think there's going to be a lot of new therapies coming out for head and neck cancer and for all cancers, because we're now, with all this genome-wide arrays and understanding how the genetics works, I think there'll be new therapies out there.
Dr. Cutler, can you hear me?
Sorry.
Correct me if I'm wrong, but it looked like one of the slides showed 0 for esophageal cancer for the FA population. Do you still feel that way if a child was born with a TE fistula? And the other part of that would be, as parents, can you suggest, I know you recommend Gardasil and HPV vaccine, I know you discourage smoking and drinking, but what else can we do for our children? Maybe like an oral rinse or something that we can do as parents to help our kids maybe, protect themselves from getting head and neck cancer.
Sure. I guess the first question, there is a higher rate of esophageal cancer. I think in that study, I'm not sure which slide you're pertaining to, there is a higher rate of esophageal cancer. It's not, esophageal cancer, at least in my mind, is not head and neck cancer. It's more thoracic cancer. So I didn't focus on that, but I do think there's a higher rate of esophageal cancer, because if you think about the lining, it's the same kind of lining in the head and neck and the esophagus. That's the answer to question one. Question two is a very difficult question to answer. You're basically saying, what can we do to prevent head and neck cancer in general? And I think that there's a couple things that you can do that can help the patient from an oral cavity standpoint, but whether it actually changes the rate of head and neck cancer, there's no data to. For example, good dental care and good oral hygiene is important. Now, whether poor oral hygiene causes cancer, no one really knows that information at that point. If you look at a lot of my patients who are the smoker drinkers that I was talking about before, they have terrible oral hygiene because they're alcoholics and they don't take care of themselves. So there's a lot of confounding factors. In other words, are they smoker drinking alcoholics who have bad oral cavity hygiene, or is it the oral hygiene that's called, it's a little difficult. So the bottom line is that obviously good oral hygiene, good dental care is important for everybody, and I think that it can definitely make the environment better in the patient's mouth. Now, one of the clinical trials that I was dealing with, and the data has not been released yet, we were looking at ways to try to prevent leukoplakia and dysplasia from progressing into cancer. It happened to be a drug called pioglitazone. And the bottom line is that we don't have enough data on that drug, but I think in the pipeline there are going to be drugs that basically try to prevent these precancerous lesions from progressing into cancer by changing the environment of the mucosa. At least, again, anecdotally, I treated, at least on this trial, with 10 patients with this particular drug, and it was a blinded study, so I didn't know whether I gave the drug or didn't give the drug, so it's hard for me to really say anything. But I got the impression that some patients, the leukoplakia seemed to get better. But again, I don't have I was blinded and the data hasn't been released yet. But it will come out in the future.
So, Marianne?
Yeah.
Hi. We're all keen on early detection in this room. I don't think there's a parent in here who's not worried about early detection. Some of us talk to each other, and we've noticed that there's a difference in the teenagers who are starting their screenings twice a year.
Right.
Should they be scoped or not? Some
Yeah.
just do a visual check, some do a scope, some are more thorough. You know, some parents are asking other parents what extent of the exam is. What do you recommend when they're starting at 12 years old?
Right. I think this is the third time I've given this talk, and this question gets asked every year. And it's a hard question to answer. I personally think that to really examine the entire head and neck region, I think a scope is definitely a better exam than using a mirror, or just looking in the back of the throat. Because if you think about it, if you just look in the oral cavity, which is the normal oral cavity screen, you're looking at you can see the soft palate, you can see the uvula and the tonsils, you can't see the back of the tongue, you can't see the voice box, you can't see the top of the throat or the hypopharynx. Now, there's a mirror you can use, which it's like you ever see those dental mirrors? You can basically pull out the tongue and then stick this mirror in the back of the throat and then kind of get a visual down without doing a scope. I would say, and I've done both, I know how to do both of those. I think for like a teenager, the scope is probably easier to tolerate than me sticking a mirror in the back of his or her throat. So I like to do the scopes. I think it's a more complete exam. But if you look at the locations that most of the Fanconi anemia patients got their tumors, it was mostly in the oral cavity. There were some larynx cancers, there was some hypopharynx cancers, but most of them were easily seen in the mouth. But I do think that a complete exam is better with the scope, and I think easier than the mirror. Now that being said, you have to weigh each patient differently. I mean, I see probably about 60 to 70 patients a week. And I see some kids, not a lot. But the bottom line is that most 12 years and older can tolerate the scope. You can use a pediatric scope, which is pretty small. And to be frank with you, if done correctly, the flexible scope in the nose, even though it really sounds scary to patients, and I can't tell you how many times I'm like, okay, here's the scope, I'm gonna put this in your nose. They're like, my God, But then when I do it, they're like, that didn't hurt at all. And it usually doesn't hurt. It feels a little weird. And I've had it done to myself, by a medical student, which is not what you want. But, the bottom line is it doesn't hurt. It doesn't hurt if it's done correctly. And I think it's more of the fear of having something in your nose than anything else. So I would suggest that we do it, and I think it's more of a complete exam, looking at the larynx and hypopharynx and the kind of the back of the tongue, which you can't really see very well, even with the mirror.
Okay, and as a parent, I just want to tell other parents that Peter just had it done this week, and it was nothing.
Yeah.
They spray the little numbing thing in the
Right.
nose, and
Yeah,
he was very good.
the numbing spray that I use smells like vanilla on purpose. So I always say it's, and I've done it to 12-year-olds and even younger patients. And I think the bottom line is, if done well, the pain is really minimal, if anything. More just weird feeling.
Well, that was my question. Thank you. But I have another one. Do you have any concerns, Dr. Cutler, about creating trauma that is purely cosmetic, like braces or cosmetic jaw surgery in kids with FA, in terms of just introducing a trauma to an area that's already prone to problems?
Yeah, I mean, there's no evidence that trauma causes cancer in the oral cavity. So I think that any trauma, like getting dental work or getting braces, there's no increased rate, in my opinion. So I think those are things you can do, safely without any issues.
I think we only have time for a couple more questions. But David, do you have any time to stay?
Yeah, I'll stay. If anyone wants to talk to me, I'm happy. I'm happy to stay as long as you want. My wife she's on a boat somewhere, so.
That'd be great, yeah, because we don't want people to miss the dermatology stage.
Oh yeah, I'm sorry. I'm sorry I took too long. I apologize.
Oh, no,
Yeah.
not over. I just mean if they can ask you after
Sure.
outside or something.
Sure.
Great, okay. So, Lynn and then David?
Yes, I believe it was in in 2008, but I'm not positive about the year, Dr. Arlene Auerbach from the Rockefeller did publish a study about cancer frequency risk in carriers of Fanconi anemia.
Okay.
And she did find that when parents were carriers of those downstream genes, downstream of D2, they did have a higher risk of breast cancer. She also included FANC-C in that group, and I know that's been a little bit controversial in some of the articles that have followed since then. But as you know, BRCA2 is one of our Fanconi anemia genes. Certainly people with BRCA2 are at very high risk of breast cancer and ovarian cancer. So that study was published. I have it at home on my desk.
Thank you.
Yeah.
Thank you.
Hi. Yeah, I mean, radiation is obviously a hot topic within FA patients.
Yes.
And I just wanted to ask about some of the patients you've treated, especially with radiation, about thymic screening.
I'm sorry, I didn't hear.
Thymic screening? You screening the thymus?
Treating the thymus. Okay.
Shielding, sorry. Sorry, shielding.
Shielding of the thymus. Yeah. Okay. You know, I'll be honest with you, I'm not a radiation oncologist, so I'm a surgeon, treats head and neck cancer. So I don't know a lot about that, to be frank with you. I think that areas that don't need to be treated by radiation are generally shielded. If you look at how most of the radiation that's done nowadays is something called IMRT, which is a fancy name for intensity modulated radiation therapy. Have you heard of that? And what it is that they have a very fancy computer, which basically, and the radiation oncologist, and this is used pretty much across the board in most big cancer centers, and pretty much everywhere at this point. And what they can do is radiate areas that they want to radiate and not radiate areas they don't want to radiate. So in other words, very targeted radiation therapy. It used to be, they used to just take beams and come across the head and neck and everything used to get radiated. Nowadays, they can, with IMRT, can only isolate a small area that they want to radiate and then try to avoid other areas. One of the issues with head and neck cancer is that you have to, a lot of times, treat the lymph nodes with the radiation, in other words, the lymph node beds. So the area that you're radiating is still pretty wide, but you're still able to try to avoid radiating the thymus, radiating the spine, radiating the jaw, which over a certain amount of radiation can be damaged with it.
I think we have time for one last question. Have you done a study about pre- and post-transplant in FA patients, what the correlation between head and neck cancers are?
Yeah, probably Blanche Olter was the one who I think did that study over there on the side there. You know, I think there was some potential increase rate of head and neck cancer or cancers with the transplant. But you know, the bottom line is that in the study that I was doing, there wasn't. But I think our Blanche's was a better study by far. So yeah. See Blanche? I still yeah.
In all fairness of disclosure, the study was reported in 2007, and it was an analysis of the transplants done by Ilian Gluckman's group in Paris during the preceding 25 years, compared with our own group of patients who had never had a transplant. So there's a component there, which was that there was a higher incidence. Well, everybody who'd gotten transplanted had had radiation as the transplant. And the transplant modalities, as you all know, have changed dramatically. But the bottom line that was probably the association was chronic graft versus host disease. So the newer modalities of transplant have a reduced incidence of graft versus host disease. But our expectation, unfortunately, is that those in whom that does occur, despite the lower incidence, will still have a higher rate of head and neck cancer. And the real aim is to get rid of graft versus host disease, which, again, some of the newer modalities are aiming to do. But since it took 25 years worth of previous transplants to gather enough data to be truly very statistically significant. There's a fourfold higher rate and a difference of about 16 years earlier for the head and neck cancer. But I think more time is needed until we can analyze current
Right.
transplant modalities.
Has there been any other studies on that plan? as far as you know?
Unpublished, but confirming the association with graft versus host disease.
But how about just bone marrow transplant?
That's what I'm
alone?
talking about. Transplanted patients, even with the newer modalities with graft versus host disease, still had a higher rate of head and neck cancer. But this is unpublished, totally anecdotal,
Right.
and I'll defer to the transplanters and to when we get around to analyzing John's data.
Yes, I just want one clarification. You actually ended 5 minutes early, so
Okay,
thank you.
thank
So we
you.
had more time for questions. And let's thank David for his wonderful
Thank you.
talk.